Thank you. Just before the break, Professor Steer, we were discussing overwhelming hemorrhage. Can we talk now about other hemorrhages which would still be considered major? Can you talk us through how a major obstetric hemorrhage was managed in the 1980s and early 90s? And then I'm going to take you to some much later guidance.
The first point is about the definition. For many years, the traditional definition was greater than 500 millilitres. But as I pointed out in some of my publications, an average healthy person can give a unit of blood, which is usually it's about 500 millilitres, without any significant adverse effects. And the average woman who gives birth will commonly lose about 500 millilitres anyway. So her circulating volume decreases once she gives birth, so she doesn't need as much blood. So we can argue that the first 500 millilitres is normal, because it's what usually happens. And then an additional 500 millilitres can usually be compensated for without any particular difficulty. So currently, both the American College and now the Royal College have taken to using 1,000 ml. So the Royal College now talks about minor postpartum hemorrhage, which is 500 to a litre, and then major as being more than a litre, whereas the American College have just said below a litre, it's not a hemorrhage, a significant hemorrhage. So above a litre, we can say it's a postpartum hemorrhage. I'm not aware of a specific definition for major, or shall we say massive obstetric hemorrhage, but basically anything more than about 2 litres is likely to need some form of augmentation of the blood volume, because by this time the woman has lost the 500 ml that we could say, okay, she can cope with that, no problem. Another 500 is not difficult. As soon as you get another 500, there's a risk that she will start to decompensate. In other words, her blood pressure will start to drop and she won't be perfusing her brain properly and so on and so forth. So once we get to 1.5 litres, certainly 2 litres, we're thinking about replacing the circulating volume, which initially will be done with crystalloids such as Hartmann's, which is a solution that is made up, stood the test of time. It seems to be appropriate and very useful. It's not then until now, we would say, the hemoglobin starts to go below 70 grams per litre that we'd start thinking about giving blood in the form of packed cells to replace the oxygen carrying capacity, which is decreasing because the blood is getting diluted by the fluid that you're giving. It would have been 80. Certainly, if a woman had, we're going back 20, 25 years, if a woman had lost several litres of blood and her blood pressure had dropped and a hemoglobin estimation had been, say, 7.8 grams per deciliter. So they keep changing the unit. The SI unit is in grams per litre, but traditionally in the UK it was grams per deciliter, so it gets a bit confusing if I jump between the two. But anyway, if there was hemodynamic decompensation, the blood pressure was dropping, there was concern that there might be ongoing hemorrhage and the hemoglobin was below 80 grams per litre, that's the point at which we would think about giving red cells. So you then give a series of red cell transfusions to keep the blood pressure up. Usually when you got to having given, say, 5 packs of red cells, you'd start to think about, do we need to start adding in the clotting factors, such as fibrinogen, such as platelets, because with that amount of blood replacement, the clotting factors cannot be produced by the body rapidly enough to compensate. So you need to start giving them artificially.
And in that more emergency scenario where you're having to use colloids and red cells, who is making the decisions about what to transfuse and how much to transfuse?
Primarily, it will be the anaesthetist, because the anaesthetist will be monitoring the woman's blood pressure and her pulse rate, her respiratory rate, her oxygen saturation. So he's got a lot of information, and that's his specific role, to be monitoring those. The surgeon is usually, the obstetrician is usually busy doing the surgery. The surgeon's role in that situation is to keep the anaesthetist updated with the degree of blood loss that they see is happening. Say, you know, she seems to be losing a lot, can you watch out, you know, or we're not getting on top of this, she's still bleeding, we need to do more. you may need to give her a transfusion. But the actual decision would normally be the anaesthetist.
And in that scenario of the very significant hemorrhage, has practice changed over time in relation to when a transfusion is given, or is that a better question? We've got an obstetric anaesthetist this afternoon. Is that a question better directed to him?
I think, yes. I don't recollect any obvious change in the sense that if the woman is decompensating and there's ongoing hemorrhage, there would then be consideration for giving red cells as well as the colloid. But as you suggest, I think the anaesthetist would give you more chapter and verse on that.
And then if we come down a step in the spectrum to, I think what you said the Royal College is calling a minor postpartum hemorrhage, who would make the decision then on what, if anything, to give in terms of blood and blood components?
Well, if there'd been no change in the woman's vital signs, the anaesthetist hadn't expressed any concern, and the blood loss had been less than a litre, I don't think many obstetricians would have suggested giving a transfusion. A few might, but I don't think the majority would have suggested a transfusion at that level.
In terms of your own practice of giving blood, let me just turn it up, sorry. In terms of your own practice, do you recall needing to give blood in those situations and giving just one unit rather than two, whereas colleagues might have given two? Or is that a different situation?
Yeah, I mean, my policy was to start giving Paxil. I mean, very often I wasn't actually making that decision. It was the anaesthetist. And they would be giving red cells according to the level of ongoing blood loss. So what would be happening was that the blood would be being collected, the drapes would all be being hung up one after the other, so that the anaesthetist could have a clearer view of how much ongoing blood loss there was. And on the basis of that, they would calculate how many red cells might be needed to replace the loss. It wasn't something I remember specifically discussing with the anaesthetist. Usually one was too busy doing the surgery to think in those terms.
Moving forwards in time, if we could look at RCOG 5020_012, please. This is a Greentop guideline from February 2007 from the Royal College. Just for those listening, can you explain to us what a Greentop guideline means?
Well, there are various levels of guidelines. Guidelines started coming in really in the 90s, and then they were taken up by the National Institute for Clinical Excellence, or Health and Clinical Excellence as it became. And the NICE guidelines are national, and they do very detailed systematic review of the literature and have a large committee deciding on what the recommendations should be. But there are more aspects of care than can possibly be covered in national guidelines. They would just simply be, they're extensive enough as it is. We're talking about hundreds of pages of national guidelines, which is actually one of the problems in that trainees often say they don't have enough time to read all the guidelines, let alone implement them. But there are many other issues which don't rate national guidelines, which nonetheless the Royal College feels there should be guidance for trainees and a sort of recommendation, and that's then put out as a Greentop guideline.
Thank you.
So it's advisory rather than a sort of national guideline.
Thank you. We can see that this is the first edition of the guideline on blood transfusion in obstetrics. Can you assist us at all with why it's only in 2007 that there is a first guideline on blood transfusion in obstetrics?
Not specifically, other than if you went back more than 10 years before that, there were almost no guidelines at all. So it's simply a question of what you prioritise first. And I guess it took a while just to get round to this, because
There are so many. I think there are about 40 Greentop guidelines now.
This one is guideline number 49, we can
14,
see.
oh yes,
it's,
more than that, yes.
In 2007.
Yeah.
If we turn then to page 4, we can see the heading of management of major hemorrhage. What's your understanding of the degree of hemorrhage that this then applies to?
Well, as I've said, there have been these discussions and changes in how we categorise postpartum hemorrhage. In terms of major, as far as I'm aware, the definitions depend on who's been doing the study. I'm not aware of a sort of generally accepted value.
We'll pick it up in the next guideline I want to look at, which is 2009. I just wasn't sure if it was different. We then just see under the heading red cells, where there's no history of irregular antibodies and none are detected, group-specific compatible blood can be provided within 10 minutes plus transport time. That's the recommendation. If irregular antibodies are found, then blood must be cross-matched. Then turn to the next page, please, Sally. In an extreme situation or when the blood group is unknown, O-RHD negative red cells should be given. And we see that note grade C. That's the level of importance attached to the recommendation, isn't it?
It's best clinical judgment rather than based on data.
And then under the heading fresh frozen plasma and cryoprecipitate, we see in the bleeding woman with disseminated intravascular coagulation, a combination of FFP, platelets and cryoprecipitate is indicated. And then further down, there is insufficient evidence to suggest that FFP is useful in massive transfusion in the absence of DIC. Its use should be guided by the use of coagulation tests. And then it should be borne in mind that at present in the UK, most units of FFP are not virally inactivated, and that transfusion with these products offers a small risk of transfusion-transmitted infection. And then we see the heading at the bottom of the page, platelets, and over the page, platelet counts correlate highly with microvascular bleeding. Platelet transfusion is indicated in the bleeding patient if the count falls below 50 times 10 to the 9 per litre. Broadly, does that represent your understanding of the practice in the 2000s?
Yeah.
And then if we turn on to RLIT 40946, we have guideline number 52, May 2009, specifically in relation to the prevention and management of postpartum hemorrhage. And we see in the first paragraph exactly, Professor Steer, what you were saying. PPH can be minor, 500, apologies, let me start that again. Primary postpartum hemorrhage, PPH, is the most common form of major obstetric hemorrhage. The traditional definition of primary PPH is the loss of 500 ml or more of blood from the genital tract within 24 hours of the birth of a baby. PPH can be minor, 500 to 1,000 ml, or major, more than 1,000 ml. Major could be divided to moderate, 1,000 to 2,000 ml, or severe, more than 2,000 ml. The recommendations in this guideline apply to women experiencing primary PPH of 500 ml or more. And then secondary PPH is defined as bleeding after the first 24 hours. If we then turn on to page 7, please. We see in bold the guidelines. I'm just going to read them out for those listening, and then I'll ask you about them, Professor Steer, if I may. Basic measures for minor PPH, blood loss of 500 to 1,000 ml with no clinical shock, intravenous access, and commence crystalloid infusion. If we just pause there, does that accord with your...
Yes, that would have been my practice, yes.
And would practice have changed significantly over the last 30 years or 40 years in regard to that?
It might have to some extent. The first time I can ever remember maternity being asked to about blood transfusion was actually
when I was doing a locum as a second-year clinical student. In those days, you were allowed to do obstetric locums, which wouldn't be allowed now. So I'd had about 18 months experience as a house officer. And I'll always remember it because I took over on the Thursday night, and on the Friday morning there was a booked caesarean section, bearing in mind the caesarean section rate in those days was only about 6%. So it was quite unusual. And there was the techniques in those days weren't as good, and the woman was bleeding significantly during the caesarean. And the senior registrar, who subsequently became a professor actually, I can always remember this, said to me, "We better start giving her some blood. Where's the blood?" And I said, "What blood?" And I'd been told the previous day that all the preparations for the caesarean had been made, and I got into trouble for not having cross-matched blood for a caesarean section. Now, subsequently, that changed, and the practice became to group and save, so that you could do an emergency cross-match in 10 minutes if you needed it. So, because there was no actual cross-matched blood, when that change occurred, there was less of a temptation to give it because you didn't actually have any blood in the operating theatre. So that was one of the things that started to discourage people from giving blood just in case.
And then if we look at the next part of the document, full protocol for major postpartum hemorrhage, blood loss of greater than 1,000 ml and continuing to bleed, or clinical shock. We have the airway and breathing and circulation matters, and then the bullet point, transfuse blood as soon as possible. Until blood is available, infuse up to 3.5 litres of warmed crystalloid Hartmann's solution, 2 litres, and or colloid, 1 to 2 litres, as rapidly as required.
And the important thing there is the continuing to bleed or clinical shock rather than the amount of blood loss. Those are the key reasons for giving the blood.
And then if we go towards the bottom of this list, in fact we can still see it on the screen, fluid therapy and blood product transfusion, we see the specifics in relation to that, picking up on the blood. It's been cross-matched. If cross-matched blood is still unavailable, give uncross-matched group-specific blood, or give RHD negative blood. Fresh frozen plasma, 4 units for every 6 units of red cells, or particular prothrombin, thromboplastin times. Platelets, if platelet count is less than 50 times 10 to the 9, and cryoprecipitate if fibrinogen is less than 1 gram per litre. And then if we turn over the page, we see the heading, apply clinical judgment in each situation. The cornerstones of resuscitation during PPH are restoration of both blood volume and oxygen carrying capacity. Volume replacement must be undertaken on the basis that blood loss is often grossly underestimated. Compatible blood, supplied in the form of red cell concentrate, is the best fluid to replace major blood loss and should be transfused as soon as available if necessary. The clinical picture should be the main determinant for the need of blood transfusion, and time should not be wasted waiting for laboratory results. And then this, obstetricians should draw on the expertise of their colleagues in anaesthesia, haematology and transfusion medicine in determining the most appropriate combination of intravenous clear fluids, blood and blood products. And then it refers to the 2006 haematology guidance on massive blood loss, that the main therapeutic goal is to maintain hemoglobin above 8, platelet counts above 75, prothrombin at less than 1.5 times the mean control, the same figure for activated prothrombin times, and fibrinogen above 1 gram per litre. Again, to what extent does that accord with your understanding of practice?
Indeed.
And has that changed significantly over time?
Well, over time, yes, because the ability to give specific components, such as the platelets or the fibrinogen, has changed completely. I mean, when I started, you just had blood and that was it. And then you had the packed cells, and then the components came along later. So there was a constant evolution of the process, so it didn't stay the same. And that's always been a challenge for consultants to keep up with those changing availabilities, because they might suddenly be told, we don't give whole blood now, we just give packed cells. Oh, right, so that's how you found out. And then similarly with the clotting factors, it was a process of evolution. You were updated by being told what was current at the time.
I want to pick up that point in a moment. If we can just finish off
Sure.
the hemorrhage
Sure.
point first. In a situation of a major hemorrhage, what would a woman be told about the transfusion at the time?
Well, assuming she was conscious, she would be reassured that all measures were being taken to safeguard her life. I don't recollect, bearing in mind that I was doing the surgery, so I wouldn't be necessarily aware of what the anaesthetist was saying to the woman, but I don't recollect that she would be told, oh, you're going to have cryoprecipitate now or whatever. It would just be, we're giving you the right stuff to keep you in a good a state as possible. But I couldn't really, so you'll have to ask the anaesthetist about that.
And then, if that information detailed information couldn't
Yes.
be given because of the emergency context of the situation, whose responsibility would it be to talk to the woman after the situation had resolved?
Yes, I think I've mentioned that in my statement. That's an interesting one. Certainly in the mid-90s, we became concerned to make sure that people were being given more information about what had actually happened. And that importance has only increased because of all the recent inquiries and so on. And so I actually designed a pro forma that the surgeon was meant to, at the time, or was asked at the time, to fill in the details of the procedure, what had happened, if they'd been given transfusions, etc., etc. There was a certain degree of resistance amongst my colleagues because this was quite a lot of extra work, because then they had to not only fill the form in, but they were expected after 24, 48 hours to go and see the woman and go and give them the form and explain to them what had happened. And what finally stopped it was we actually had a formal complaint from one woman who said she was recovering and perfectly happy that everything was fine. And then suddenly somebody came along and told her that she'd nearly died while she was being delivered and so on and so forth. And now she was getting nightmares and anxiety, and she should never have been told that. Now, whether she was told it in a bad way or not, I have no idea because I wasn't there. But there was concern amongst my colleagues that this needed rethinking and that there was a danger in giving people too much information, which is a valid point of view in some respects. And that perhaps the emphasis should be to simply say to women, would you like more information? And then give them on an ad hominem basis, as it were. And that's what we ended up with. It was partly because it was making a lot of extra work and partly because we'd had some negative reactions to routinely giving people information that they hadn't necessarily been expecting or indeed been aware of.
So just, can you roughly date when you instituted that system of information from the surgeon in a more structured fashion?
It was up while we were at the West London Hospital, so it would have been between 1989 and 1993. I can't time it, somewhere in that time period.
And before 1989, what was the process? How much information was given to women after a caesarean or after a major hemorrhage where they had received a blood transfusion?
Well, there would have been a ward round in which the woman's condition was reviewed, and she might well have asked questions about what happened. It was then up to that clinician who was doing the ward round to tell her from the notes what had happened. Now, because the notes always don't give an entirely complete picture, that's why I suggested that it should be the surgeon who did the procedure who would debrief the woman. And that was part of the problem, I think, that it was simply, that made it very time-consuming for them to seek out the woman they'd operated on. And that was in a day when people had their own assigned consultant. I mean, talking to colleagues yesterday, certainly at the Chelsea and Westminster, women are no longer assigned a consultant because so many people are working part-time and intermittently that it's no longer practical. So they're just booked under the hospital. So it does become the responsibility of the person actually seeing the woman to give them the best account they can from the notes, from the records, without necessarily having, in fact, commonly not having been there at the time.
which presents its own difficulties, obviously.
And would entirely depend on the information being in the notes.
Exactly.
Just going back, apologies, to before 1989 again, you indicated that it would be on a ward round, and if the woman asked for information, it would be given. If a woman didn't ask for information, does that mean that it wouldn't be provided to her in terms of you've had a transfusion?
No, there would have been no routine reporting of what had happened, other than what the clinician doing the ward round felt was appropriate and that she needed to know. And that would be up to that individual. And it was in an attempt to try and standardise this and make it a little bit more explicit in what we expected women to be told that I produced this form. Yes. I did look in my records to see if I still have it, but I didn't have it. So it just, I think we implemented it for about 8 weeks or something before people started complaining and saying it wasn't appropriate, and so we stopped.
And once that more structured approach stopped, you've said in your statement that it then became clinicians making individual judgments again as to how much would be told to a woman. Was there any guidance to steer them on how much information as a clinician you should give someone?
Not that I'm aware of. One of the changes that did take place in the 80s and then the 90s was the move to letting the women carry their own notes. And so that continued. So if a woman wanted to look at her own records after she delivered, then of course that was considered entirely appropriate. She wouldn't be prevented from doing that. Although a lot of women were then surprised to find that the notes were then taken away from them once she left the hospital, because they, at the time, and I think it's still probably the case, the notes, the clinical notes, they don't belong to the doctors, they actually belong to the Secretary of State, and they're kept by the hospital. And that means that they're then stored somewhere. And so, for example, because we ran out of space at Chelsea and Westminster at one point, the medical records department moved off-site to somewhere like West Drayton or somewhere, and then there was a huge fire. So for a lot of women, all their records had simply gone up literally in smoke. That's been resolved to a large extent by the electronic record systems that are now largely in place.
But at that time, when it was down to clinicians' judgments on what was said, I've been asked to ask whether that resulted in a very paternalistic approach, with clinicians deciding for a new mother that she didn't need to worry herself about potentially distressing information about a transfusion.
I think that was quite a common attitude, yes.
What about in relation to a patient's GP? What information was provided to a patient's GP?
Well, that again evolved in time. I can remember as a registrar at Kingston, each week, when I found the time, writing discharge notes to the GPs on about 80 women a week. So it was quite a task, usually done in the small hours of the morning, because that was about the only time it was quiet enough to do it. So when I was involved in helping to develop the Seconia Maternity Information System, one of my priorities was to extract as much information as possible into a discharge summary, which in fact became a page of A4 with lots of all the detail we collected and put on the computer was then sent to the GP. So I was quite instrumental in helping to design that, to make sure that they had as much information as was practical that would give them as complete a picture as possible as to what had happened.
And that would include whether or not a blood transfusion was given?
It would certainly include, yes, as I recollect, it would have done, yes, because we collected how many units of blood the woman had transfused. And without looking at it again, I can't be absolutely certain, but my recollection is that we did include that in the discharge summary.
And what time frame was that?
So we implemented that at St Mary's in the form of tear-off sheets and punch cards and using a PDP-11 computer in the late 70s. And then we put it on to a PET Commodore microcomputer. That would have been about 81, 82. And then by about 1985, it was being run by ICL. And then in 1988, it was pushed out right across the Northwest Thames. That's where we got the 17 maternity units involved, all collecting the same data. And that's the data set on which we've done so much research since.
And even as early as that, that would be provided in the discharge letter to the GP?
Pretty sure it would, yes. I'd have to check, but I can't see any reason why we wouldn't have put it in the discharge.
And then in terms of hepatitis C particularly, when you were discussing transfusions with women, how often was the risk of hepatitis C discussed before screening was introduced in 1991?
I don't recollect ever having mentioned it specifically, other than there is always a risk of viral infections which can affect your liver, would be the sort of way I recollect it would have been put, rather than being particularly specific. Probably the impression would be that whether it's hepatitis B or hepatitis C would not be particularly useful information for the women. And in fact, it was hepatitis B which was much more prevalent in the area in which I was working, because it was quite common for women from South China and Hong Kong, for example, to be carriers. So it was quite a major issue, the hepatitis B carriers. So they would be immunized, and then the babies would be given immunoglobulin and so on. So there was quite a well-organized process for informing women about hepatitis B, and getting their family screened. In fact, we would ask all their family to come up for screening. And in that process, sometimes cases of hepatitis C would be picked up, but I don't remember such a specific program for hepatitis C.
And then in relation to both general anemia and hemorrhage, would there ever be any follow-up by an obstetrician of a woman who had had a blood transfusion when she was delivering or when she was in hospital?
Not specifically in relation to the blood transfusion that I can remember, no.
So if a woman felt generally unwell post-birth, would there be any mechanism for her to contact an obstetrician?
During the postnatal period, it was again customary to have a postnatal check at 6 weeks for many, many years. That's now been largely abandoned because it wasn't very productive. But until that 6-week period, it was quite common for women to contact us as obstetricians. After that, it was generally felt to be the responsibility of the health visitor and the GP to contact us subsequently if there were ongoing problems.
So if, as in much of the evidence that the inquiry has heard, women have had symptoms that have been later identified as being arising from hepatitis C, that's not something you would particularly be aware of because it would go to the GP.
I don't recollect ever having been informed personally of anyone that I'd been involved with having hepatitis C.
And I just want to move to my final topic with you. We've looked at a number of sets of guidelines this morning that have been produced by different bodies. And you've said today and in your statement that in the 1990s guidelines began to be produced. You yourself produced a set of guidelines along with your then senior registrar and the partner of the law firm Capsticks. Can you tell us what that involved? What did you do?
Well, basically, we were concerned that there was a proliferation of guidelines coming out, not just from NICE, but from the college and the Greentop guidelines, that there was no specific mechanism for making sure these were available to all the staff. As far as I know, there still isn't. So when a guideline's produced, it's the responsibility of the clinician to go online or whatever to look them up and find out about a change in policy. It's a sort of reactive rather than proactive arrangement. And so what we were finding was that there might be a Greentop guideline come out or a NICE guideline that we as consultants, senior obstetricians were aware of, but it hadn't still percolated into the junior staff because there was no formal training program. I mean, it might be worth just saying about the training of postgraduates. In the early 2000s, the Kalman training program was introduced, which was an attempt to make training much more structured. And this involved moving juniors every year to a different maternity unit. And the idea was to give them broader experience. On the other hand, it did disrupt the continuity of linkage with senior staff and so on, which I was concerned about. So in fact, in North West Thames, with Professor now Dame Leslie Regan and Professor Murdo, she was at St Mary's, and Professor Murdo Elder, who was the professor at Hammersmith, I actually set up a training scheme that was going to be 3 terms of 10 weeks each year, so 30 weeks in total, where the trainees, that's all the junior doctors, all the registrars up to senior registrar level, would be gathered together for 1 afternoon a week on a Friday.
Sorry, just to be absolutely clear, when you talk about junior doctors,
Yes.
it's anyone below a consultant.
Correct.
Yes.
Yes. They're still in training.
Indeed.
And the idea was that I then set up a curriculum so that that was 30 sessions per year over 3 years. So we had 90. So I arranged a curriculum for all 90 sessions, at which things like all these new guidelines coming out would be specifically covered. So they would actually be they'd be presented and discussed and so on and so forth. And for the first year, that worked. And then the next year, I discovered that the junior doctors were attending intermittently, and I'd got other consultants involved. It wasn't just me doing the teaching. And then by the third year, we had a lot of pushback from the trusts who said, you're taking our juniors away for a whole half day every week for 30 weeks in the year. We can't afford to lose them. We're short-staffed, there's rota gaps, blah, 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 and it all stopped. So since then, there's been, it does concern me, a serious lack of formalised sessional teaching in that way, where you actually have a curriculum and you set things that need to be. In North West Thames, the juniors themselves set up, they were given an afternoon a month, and they set it up themselves. And until last year or so, I've been regularly participating in doing them whole afternoon seminars. They've obviously, since COVID, had to go online. But they decide what topics they want covered, and so on. So my feeling is that part of the problem with all these guidelines and papers that are coming out is that when I do a presentation to the trainees, and this was literally within the last 3 or 4 years, I'd ask them about a specific guideline and they wouldn't have seen it because there's no formal mechanism for making them aware of when they're, and then requiring them to read them and then be sort of quizzed on them, if you like. And I think, personally, this is a serious deficiency. And I know this is something that our Royal College is very concerned about, because with the current shortage of staff, and we've got to bear in mind that something like a quarter of trainees abandon their training before they complete it. So that's another big problem. The problem with all these guidelines is they're not readily. So now this is a long-winded way of saying why we set up the DATIC system. So what we then said was, we've got electronic terminals, and at that point we had about 2,000 at the Chelsea and Westminster Trust. So why don't we put all the guidelines on a central server, and then if the junior doctor, and again I'm talking up to anyone up to consultant level, suddenly thinks, oh, I'm dealing with condition X, I better check the latest guideline, they didn't have to go off and find them. They could sit at their ward computer, call up the DATIC system, and there was the guideline. And I was really pleased that, after we'd introduced this system, I would commonly go on the ward and I'd see the junior doctors sitting reading the guidelines on the terminals. And I thought that was really a big step forward. And since then, lots of other trusts have obviously done the same thing. We were the first in our department, Obs and Gynae, because we pioneered it, were the first to set it up at the Chelsea and Westminster. And then medicine and surgery said, oh, this is great, and so they did it. And then it became standard for most of the disciplines. So this is where the idea came from.
And then, as far as your understanding is, it's gone out from Chelsea and Westminster to other trusts as well?
Yes, I've never done an actual survey, but DATICs operate nationwide, so I presume there's something similar in most places.
I've been asked to ask why a lawyer was involved in the development of that work.
As always with these things, there was no funding initially for the equipment to set up the server, to get all the guidelines put online. And I'd done quite a few medico-legal cases with Brian Capsticks and got to know him quite well. And to his credit, he said, we're making a good living out of all these disasters. Perhaps we should think about putting something back. And so he very helpfully, and his company, funded this development. Now, I then had a meeting which I convened with the Deputy Chief Medical Officer at the time, Aidan Halligan, together with Brian Capsticks and representatives of our trust. And the idea was that we would franchise this system across the country, and this would make this advantage available nationally. And unfortunately, that was just the time when the National Programme for Information Technology was launched. And that was going to be a top-down, NHS-wide information system. And they said, we don't want all these small developments going on. It's a distraction. And in fact, Aidan Halligan rang me the night after we were due to have the meeting, because he didn't turn up, and said, I've been told not to go ahead with this because it will interfere with the National Programme for Information Technology. I said to him, I don't think that will work, doing it top down. He said, well, neither do I. And not long after that, he actually resigned. The National Programme for Information Technology, I think in total, cost 12.4 billion. And it never really produced any worthwhile outputs. And unfortunately, it did put, it slowed down the development of local guidelines in the way that I've described quite substantially. Now, my idea was that we would franchise the guidelines to all the other trusts, and they would pay us, £2,000 a year, and we would keep all their guidelines and so on updated. But of course, it just never happened. That was the end of that particular development.
We've looked at a number of guidelines earlier, which were general haematology guidelines rather than obstetric guidelines. What degree of interaction did you have with haematologists at the hospitals you worked in?
Nothing specific that I can recollect, no. Each discipline was responsible for setting up their own guidelines on the DATIC system.
And even before the DATIC system, how much interaction did you have with haematologists about blood use and risks arising from blood transfusion?
Very little that I can recollect.
And you said earlier that the way, as a clinician, you discovered there was a different component available was simply being told that it was available. Again, what discussions were there about, have you thought about using this, or we're now having this component instead?
You see, there's not really a properly organised system for making these decisions generalised. To give an example, towards the end of my practicing career, I was actually sitting in a clinic specialising in women with heart disease, and I had a consultant colleague sitting with me every week. She did that for 4 years so that I could pass on what knowledge I learned. And she took over the clinic from me when I retired from clinical practice. And I remember one day she said she started talking to the women about pertussis vaccine. I said, oh, that's interesting development. I didn't know about that. No one had informed me, as a consultant looking after pregnant women, that this was now a policy. So, of course, I quickly got myself up to speed, and we advised women appropriately thereafter. But it highlights the fact that there isn't a generalised system for promulgating these sorts of new policies or decisions within the NHS. It's still very ad hoc and left to people sort of reading about it in the BMJ or something.
And you've spoken in your statement of running a perinatal meeting of your obstetric colleagues, yes, neonatologists and associated specialists to consider how things were working in the maternity service. Yes. Did a haematologist ever attend those meetings? Not
a haematologist, but a representative of the pathology department. It did, and I put that in my statement.
That was a consultant microbiologist.
Yes.
So concerned particularly with perinatal and sexually acquired infections.
Correct.
But at those perinatal meetings then, would it be fair that there wasn't such focused discussion on blood transfusion, blood components?
I don't recollect such specific discussions, no.
You've also said in your statement that you don't recall any systematic monitoring of transfusion-transmitted infections.
Well, I presumed that would have been the responsibility of the haematology department and in particular the blood transfusion section. So I didn't see that as something that was within my responsibility.
In relation to haematology and the linkages with obstetrics, was there a hospital transfusion committee in the Chelsea and Westminster Hospital?
I guess there probably was, but I wasn't really aware of it.
That was my next question. What involvement did you have with it?
No.
And with the benefit of hindsight, do you think that more involvement from a haematologist in obstetric meetings or more involvement of obstetricians in the hospital transfusion committee might have changed practice, particularly in relation to those clinicians you spoke of who you were trying to encourage to be more conservative in their approach?
Yes, it might have helped, although very often I perceive that if you asked a haematologist to come and be involved in a clinical discussion, they were quite likely, in my experience, to say, well, exactly when and how you give blood will depend on your clinical judgment, and that's not something as a haematologist I'm really competent to judge because I don't have that training. So they would tend to give us the responsibility of deciding when to give a transfusion. So there didn't seem to be an obvious or important interface that we needed to have on a regular basis.
And was there any education work done by the haematologists, or could have been done by the haematologists, with the obstetric team about better blood transfusion or more appropriate blood usage? Do you think there would have been a role for them in that context?
Well, it might have been a good idea, but I don't recollect it ever having happened.
You've said in your statement that there's still a substantial need to educate clinicians about the importance of minimising the use of blood transfusion. What do you consider is the best means of undertaking that education?
Well, as I've said, my own personal view is that there should be more regular training sessions, particularly for the training grades, which are formalised and have a curriculum and which we know what is being told to them and that they're expected to read the guidelines and learn about them and so on. As far as senior staff and consultants are concerned, there are regular updates every year, but it's mainly about the routine things such as resuscitation and moving and handling and things like this that seem to be required every year. And there are commonly not that many clinical issues that are covered in the mandatory training each year, which is usually about, well, a half a day minimum, and if you're lucky it could be a whole day. When it comes, for example, to intrapartum care, I run whole day workshops for some trusts. So just for example, last month I did an online workshop, a whole day workshop for nearly 500 clinicians across Wales. But that was on an ad hoc basis. It was something they'd set up. For many years I would regularly do that every fortnight. I would teach about 30 midwives, junior doctors about intrapartum care. And that was voluntary. I mean, it was I was doing that free. But they've since, because of staff shortage, a lot of that has been curtailed. So I haven't done that for about 2 years because they're just short-staffed. And a lot of training in maternity care is actually done by very, very laudatory charities such as Baby Lifeline, which raises millions of pounds a year to do training for obstetricians and midwives. And they're a substantial part of the training effort. And I've always thought it odd. I mean, if you went to an airport and you saw a pilot shaking a collecting box and you said, what are you collecting for? He said, it's a charity for pilot training. You might be slightly surprised. And yet, a lot of the training in maternity in the UK is still done on a charitable basis. And I've personally felt that that's not adequate. That's my personal view.
And then finally, can we look at NHBT 00837001_002, please? It's a health service circular from the 11th of December 1998, headed Better Blood Transfusion. And if we turn the page, it sets out the Better Blood Transfusion Initiative with actions for trusts, primarily in relation to hospital transfusion committees, participation in the SHOT inquiry, the dissemination of local protocols, and the feasibility of autologous blood transfusion. I just want to ask, first of all, how much you knew and became aware of the Better Blood Transfusion Initiative.
I wasn't.
Then I have nothing else to ask you about, Professor Steer, on that point. So that's not something at all that came across your desk, the Better Blood Transfusion Initiative?
Not that I have any recollection of, no. And as I've said, that's part of the problem, which is that there doesn't seem to be a very organised system for updating professionals about the latest guidelines. It's left still very much to individual responsibility, which is fine as long as when it works. But it does leave a lot to people's discretion.
Absolutely. So those are the questions I have for Professor Steer. I obviously need to speak with those behind me and those online, whether they have other questions they would like me to put. I wonder if we could take a 10-minute break, sir.
Well, will that be long enough? Because what we could do is we could break now and have an early lunch and come back then, you having picked up the questions over the break, and that might be quicker overall.
I'm content with that, sir, as long as Professor Steer is able to do that.
Would you be
Yes.
all right with that?
Yes.
It'll involve you coming back at 20 to 2. That's okay.
Yeah.
I don't know how long you'll be back for, because it's in the
I understand that there's very
things.
few. I understand from my discussions in the break that there were not very many additional questions that were
Very
being
well.
raised.
Everyone who is a participant has a right through their recognised legal representatives to ask counsel to ask questions of a witness. So I just don't know how many questions there'll be and how long it'll take. But it sounds as though it won't take very long. And I would think that you may be away by 2. But I hope that'll be, but I can't promise it, but I hope that'll be all right. Very well, 20 to 2.
Thank you, sir.